möchte ich als nächstes gerne Frau Dr. Evelyn van Weel ankündigen. Und zwar Frau Dr. van Weel kommt aus Nijmegen in den Niederlanden und hat dort ein Kommunikationstraining aufgebaut, das alle Medizinstudenten erhalten, und zwar durch ihr ganzes Studium hindurch. Die Kommunikation zwischen Arzt und Patient kann und muss gelernt werden. Viele sind der Meinung, dass man das entweder kann oder nicht kann. Das ist nicht zutreffend. Also Kommunikation kann und muss gelernt werden und ist sogar für den Arzt das wichtigste Arbeitsinstrument, wenn man das mal sich so vor Augen führt. Nur eine Empfehlung deshalb auch, es gibt ein Buch, das heißt Patientenkonferenz, es wurde initiiert von einem Chirurgen. Ein Chirurg, Sterling Edwards, hat alle seine Assistenten und Medizinstudenten in Kommunikation unterrichtet und ist das für die Chirurgie wichtig? Man hat festgestellt, wenn die Kommunikation zwischen Arzt und Patient positiv verläuft, dann sind die Operationskomplikationen um 30% geringer. Von daher hat also Frau Dr. van Weel richtige Pionierarbeit geleistet.
First of all, my apologies for speaking in English. My name looks very German, Baumgarten, but I was brought up in the Netherlands and I'm used to speaking in Dutch and in English. And the jargon is very difficult to translate into German without taking a little bit too much time. So I'm very happy that you allowed me to speak in English. I'll try to speak a little bit slowly, but if I go too fast, please make this movement and I'll try to slow down. Before starting, I would like to know, because I also like very much interactive learning, and I also am now standing in front of a large audience, I would like to know who are in the audience. How many doctors, who are doctors? Can you raise your hand? Thank you. How many students are in the audience? Not very many. How many social scientists, psychologists, pedagogists? Okay, and how many are left? How many others? And what are the others? Can I hear one or two? Is your occupation?
I'm interested in nutrition.
In nutrition, okay. And another person who was here, who was another? Oh well, yes?
Business studies.
A business, okay, that's very different. Okay, I hope you can be interested in what I will tell you. I was asked to tell about our communication and consultation skills program that we started a long time back in Nijmegen. And Nijmegen is a very beautiful and very old city on the borders of the river Weel, a branch of the Rhine, not very far from Germany. It's only 3 hours by train from here, a little over. But we also have a quite young university, and that's what I'm going to tell you about. But before I'm going to tell you about our program in communication skills, I think it is always useful to refer to the background. Dr. Mildenstein already did it a little bit, but I want to point out to the evidence that it is very important to have a good doctor-patient relationship, not just because it's nice for patients and also nice for doctors, but because it's very important to have good health outcomes in patients. And I can list many, many articles, but I've chosen 3 that I like very much myself. The first is from a review by Di Blasi in The Lancet of 2001, and anyone who wants literature, I can give my card and you can ask me for the references and I can send them to you. This is a very nice review that points out that physicians who adopt a warm friendly and reassuring manner are more effective than those who remain formal with their patients. So it's really about effective medicine. The next one was even older, and that was written and studied by Turner, who showed that a good quality of the interaction between doctor and patient has a positive influence on symptoms. And this was about pain medication. So if you give a prescription for pain medication and you do that as doctor within a good relationship with a good interaction, patients experience less pain taking the same pills as other patients who did not get that in that interaction, in that good interaction. And the final one is more recent. It was done by a Dutch psychiatrist in our country who looked at guideline concordant treatment of depression, and in this case he looked at the effectiveness of antidepressant prescriptions, and the patients who were treated according to the guideline by doctors who had good communication skills were the ones who improved most on their depression. So the depression became relieved more than those who were given the prescription for antidepressants by general practitioners who just handed over the prescription or did not have good relationship with their patients. So again here, very important to offer your treatment in a good communication, a good interaction with your patient. So that is the reason why we need good communication skills as doctors. And I'm a doctor myself, I'm a general practitioner, but it's not just about general practice, it's about medicine in general. All doctors need good communication skills. Another good thing is that communication skills can really be learned. They can be taught, but they can also be learned. There's lots of evidence by now, and I think the book by Jonathan Silverman is very worthwhile to read, and he also points to a lot of evidence. What is the best method? Not teaching like this in lecture halls. It's about skills training, experiential learning. That means practicing yourself and receiving effective, good feedback. That's the best way to learn communication skills. Again, a lot of evidence for that by now. That is also the reason why many competency profiles have been written, like probably a lot of you know about the CanMeds. It's a very international one, written in Canada. And in Holland, we too have a competency profile for our medical schools called our Dutch Blueprint. And there too, communication is one of the important competencies which has a profile written down there, and all our students before becoming a doctor have to meet the criteria of that profile. A reason why many medical schools all over the world, and certainly in a lot of Western countries, have implemented communication skills training in their curriculum. Some schools just modules, but many schools by now have started or have already implemented whole communication skills curricula. And that is most effective if you have a curriculum with repeated sessions throughout the whole training to become a doctor. That is more effective than just learning at 1 or 2 points. And there are also some rules for curriculum development for medical education that have been written down. And what I would like to do is show you the 5 very important principles that you could use when you are developing a curriculum, and they count very much for developing a communication curriculum as well. It is important to know who your learners are and what their needs are, and I will come back to these principles during the rest of the presentation a few times. It is also important to know what you want to teach them, and if you have defined that, to make sure that you also have specific measurable objectives for what you want to teach them. And if you know that, you also have to think very carefully about how you want to teach them the things you want to teach them. And of course, that's not all. You also need to make sure that you have the resources to make it work. And that's not just money and time, it's also about people, and I'll come back to that as well. And in the end, when you've developed a curriculum, it is important to find out if your learners are really learning what you want them to learn, so if your program is effective. So keep these principles in mind. Now I'm going back to Nijmegen. We started our first communication skills training, real skills training, way back in 1987, almost in the same time that you started as well, doing your fine work here in Hannover. But since 1995, we have a really integrated program that's integrated in the curriculum, that integrates communication with a lot of other tasks we as doctors have to fulfill. And the real integration came when we had a reform, when we had to reform into a bachelor-master structure because of the Bologna Agreement, a European agreement on curriculum reform. And we turned into a program called C&C, Communication and Consultation Skills, pointing at the integration of these parts. This was started in 2006, 2007, and it's not me who made it, as Dr. Mildenstein said, but it was really a cooperation, and that is very important for success, between the departments of primary care and medical psychology, but together with a committee from the faculty who was doing this reform, and with episode coordinators, and I'll come back to the episodes later, who were physicians leading the episodes in our clinical curriculum. And they were mainly specialists, medical specialists, as well as general practitioners. This is our curriculum. I'm not going to spend much time. The only thing I wanted to do is give you a little impression. It's a 6-year curriculum with 3-year bachelor and 3-year master, the clinical curriculum. It starts at the bottom left in year 1 and it ends at the top right in year 6. And if you just have a look at the light orange and the bright orange colors, you can see where the weight of the communication skills curriculum is. We prepare students in the bachelor, and those are the light orange blocks. There is communication skills in those teaching blocks of 4 weeks. And the bright orange colors are the real skills training, and that's throughout year 3, 4, and 5. And in reflection with students a little bit longer as well. And we have a sandwich model, and the sandwich model enables us in the clinical curriculum, so in the master years, to prepare students even more for the clerkships, the clinical clerkships they are going to follow in the hospital, to give them more preparation in theory but also in training, to make them follow the clerkships in a certain subject, and to reflect on those clerkships all throughout the clinical curriculum. And these cycles repeat each other many times. There are 7 clinical episodes where we have the possibility to train, but also to reflect on communication skills throughout the clinical years. How did we get started? Well, we did the needs assessment. We evaluated our former curriculum, learned about opinions, about strengths and weaknesses from the students, from the teachers, and from educationalists who were involved in the program. And of course, we also looked at the criteria in the blueprint, and we did this at the same time. We looked at required communication skills in general, broad communication skills, but also very much went into detail, looking at what types of consultations these students as doctors will see. History taking is a very different consultation from, for instance, offering a treatment, follow-up consultations, explaining about further investigation, etc., etc. We looked at the types of consultations. We looked at the different patients students would see, at groups as well. And we looked at the settings of the specialty. So for instance, general practice consultations and also consultations in surgery are very much shorter than, for instance, consultations with patients in internal medicine or in pediatrics. Those are much longer. And we thought that it would be wise to offer students the possibility to practice these kinds of consultations with different patients in these different contexts. So what we did was make a program, a longitudinal program, with preparation in the bachelor That's sometimes presentations, sometimes self-study objectives, sometimes demonstrations, interactive lectures, etc., etc. But the real skills training, we started relatively late, at the end of the 3rd year. Those were the first bright orange blocks, teaching blocks you saw. We did this very much on purpose because we wanted the students to not just learn communication tricks, we wanted them to offer communication in the setting of medicine. So if they were explaining to a patient about a diagnosis, they shouldn't be telling nonsense while using the right communication skills. So that had to be integrated, and that's why we, for the skills training, we thought about just-in-time learning around the time that they were really going to see real patients very soon. We wanted to bridge that gap between training and clinical practice for them. And this program that starts at the end of the 3rd year is followed up and followed through during the whole clinical teaching episodes, the whole clinical curriculum before and between the clerkships, as I explained about the sandwich model. We do this to consolidate the skills they learned earlier and to broaden and deepen the skills, learn new skills. And we have the possibility to reflect also on communication after the clerkships every time again, so throughout the full 2.5, 3 years of the clinical curriculum. We start simple. We give them very simple cases. We make them establish contact, find out the reason for encounter, do some history taking. We use very simple morbidity, cases with adult patients without any comorbidity, where there is attention for communication, for the context in which that consultation takes place, as well as for the correct medical content. The difficulty increases over the years, so starting simple and increasing the difficulty. We use a model for history taking and for communication. We teach them a structure and we teach them to build rapport. With this model, they have to open the consultation, introduce themselves, and identify the reason for encounter using the biopsychosocial model. They have to learn how to take a specific history with lots of closed questions. If relevant, in that context, a full history with a review of the organ systems. Then they have to learn to make and discuss a plan, and they have to also learn how to close the consultation. And they do not learn this all at the same time. We build. We start very simple with the first part, the next part, something is added, and this goes on throughout the whole longitudinal program. They then, of course, also learn about follow-up consultations, and that has lots of aspects. I'm not going to list them. I'm going to give a copy of the presentation to Dr. Mildenstein, and the ones who want to read the details can read them, and I'll also point to some references of articles that are going to be published quite soon, where you can find more details, so I don't have to read everything on the slides. So we have follow-up consultations in various patient groups, which they practice with simulated patients, and we have all these kinds of simulated patients. So we have children, we have elderly, we have people from different minorities, etc., etc. And we follow the setting for each practice session of the clerkships that are following immediately after. And I hope the films work, because I can show you 2 little examples of how that works, and you see that it really looks very real to students, and they have to some challenging topics to deal with. There's the reflection, and when they practice, they receive feedback, not all at the same time, but in a sort of rotating way by physicians, sometimes by psychologists, by the simulated patients who can really give good feedback, and by their peers, so other students. They have to prepare themselves, because we use a variety of methods, and they prepare through sometimes introductory presentations or demonstrations, and always self-study assignments, pointing to the relevant literature. But it's always followed by something experiential, and that can be a role play where students play doctors and patients at the same time, changing roles, and that is supervised by a physician and or a psychologist, but mainly we make them practice with simulated patients or actors. And also there is this supervised feedback. We also, in some sessions, make them tape the consultation. They have to review them themselves, make an objective about that, and there is always a discussion and a feedback for that student on the consultation they have taped in that case as well. I have to spend a few words on the simulated patients. All our simulated patients are trained very thoroughly in playing roles, scenarios, and giving very effective feedback. We spend a lot of time on that. We have approximately 80 simulated patients in our medical school. I forgot to tell you, we have by now year classes of 360 students each year. We started with 180, and it was quite a challenge to be able to go through this intense program with 360, but we still manage. Our simulated patients are of a broad variety. We have adults, adolescents, children 13 to 16 years. We have elderly, and we have patients from cultural minorities. And with the simulated patients, we also use a variety of methods. The most time-efficient method is the carousel model, where we have rotating patients in small groups of 3 or 4 students, which means that every student can have his own turn and receive feedback personally. And the simulated patients rotate in the student groups. But we also have, for some subjects, larger group sessions with a maximum of 15 students. It's usually 8 and sometimes 15, where we have one simulated patient or actor, and we use the start-stop method, and each student can practice a small bit of the consultation. Always supervised by physicians and or psychologists, and usually one of each, and sometimes rotating, sometimes video, and we use the actors for very challenging subjects, for instance, dealing with improper behavior or crossing personal boundaries or things like that. They have to act ad hoc and be able to play and go in and out of role. There's one topic that I want to point you to that's very specific, and I haven't come upon it in the literature, which we introduced in our program, and that is very much meant to help students integrate everything we teach them in the curriculum, communication with medical contact, but also with other procedures. We offer them the opportunity to have a surgery, and it's not offer the opportunity because it's complementary. They really have to follow this program, where they see 6 consecutive simulated patients in a surgery. We have them in 2 places, and I'll show you just a brief film from one of them shortly. There's a plenary instruction, always, and also a discussion at the end to answer any questions that are not dealt with in the small practice session. But they see a variety of consultations in the context of clinical practice, and they have to integrate communication with medical content and with medical practical skills and procedures. And they receive feedback on that. I'm not going to spend time on this slide. This is just to show you that it's longitudinal, and that for you to know that it is in the presentation if you want it, with all the subjects we deal with. This is the order of the episodes in the clinical curriculum. This means students have clerkships, work with real patients in these subjects, and this is also the order. So in episode 1, it's internal medicine, 2 UC, and 3, I've marked orange is surgery. And I would like, hopefully, it works to show you a little bit about how one of these surgery works, and I've chosen the first consultation of that surgery, where a student has to interview a patient who has bumped her head and now has a bleeding head wound, which we made to a wig. We simulated a bleeding head wound. The patient is anxious. The student also has to suture the wound in the wig, reassuring the patient and explaining about what the patient has to do after the wound has been sutured. And the student receives feedback by a surgeon in this session and by the simulated patient about communication skills. It is in Dutch, but I think even non-verbally there is enough to see, and I'll try to use only 2 or 3 minutes because I'm not sure how far I am on time, and I have a few more slides. How much time do I have left? Enough time, okay. Let's see if the film works. She's now explaining what has happened to the student, who is a little bit uncomfortable, as you can see, and there's lots to be said already about communication. And she's now pointing to where the wound is and also telling him that she's not feeling that well, a little bit feeble. And He now looks at the wound. This is the first wig. We now are into our second wig after 4 years, but it took quite long to, they suture it every time, so he tells her, accompany me, and you can lie down, and because she feels a little faint. I don't think the sound works. We'll do it like this. So he goes on with asking her questions and having another look at the wound, almost burying himself in her curls. She is very nervous. She doesn't like needles. He's telling her that he is not able to glue the wound. He really has to suture it, and he'll need some anesthetic to do that. And she's quite worried about that, but he says, well, I'll be very careful and I'll talk you through the procedure. And now he moves to the table where, as you can see, there are lots of materials, and he has to choose the right material so he can suture the wound. The first time we didn't look at the size of the needles, and we forgot to take out the needles that were too long for the patch in the wig. So that was quite a fright for the accompanying surgeon, who you will see in a moment. But by now we've made sure that all the materials are safe for the simulated patient, and nothing can really happen if the student makes a mistake. She's quite worried, as you can see. He's now going to cover her head, and she's getting even more worried because she wants to see what is going to happen. So he's playing around with, how shall I do this? And that is why students, this was one of the things that came out of the needs assessment at the beginning. When we evaluated our formal curriculum, they said, you teach us communication skills. And we learn all these other skills without seeing a real patient. And then we have to bring it together, and we really don't know what to do. We have 3 left hands. So please make us practice when we cannot make mistakes with real patients. And that was one of the reasons to introduce this kind of integrated training. There is a surgeon present. You saw him, his white coat just now, who is giving immediate feedback when something goes really wrong. So the student doesn't have to continue with the same mistake. He can immediately correct the mistake and make sure that he knows how to do it during the session. And the feedback on communication is afterwards, but the feedback on the procedure is actually on the spot immediately. So this was an example from the 3rd episode, where we do this preparation before the clinical clerkship. Then students go into the hospital for 2 months to practice all kinds of surgery difficulties. In that same preparation period, we also prepare them for breaking bad news, because they will see many patients who have had an operation and have to receive bad news. And although they are not allowed to give bad news themselves, we do train them for that before the clerkship, so they can watch their supervisors giving bad news and be aware of the official technique. So they know how it works in practice, and they have this kind of consultation skills training as well. The 4th episode is preparing for the clerkship in pediatrics. So that means, again, that they have to be able to work with children, but also with parents or grandparents or other care minders of children, and we prepare them for that in our program as well. And I want to show you another film, which is from, we have 2 sessions of communication skills training in the preparation for in that episode, all preparing for that pediatrics. And one session is about history taking with parents of children of all ages, and the other session is where they can practice 3 difficult, specific consultations in pediatrics. And I'm going to show you an example of one that is a consultation with a mother and an adolescent daughter of 13 years who have different views on the health problem. The girl has a headache. She has a headache sometimes, but she also sometimes just uses the headache to skip school. And the mother, on the other hand, is very worried because she has developed a migraine starting at that age, and this mother is very worried that the daughter has a migraine as well. And the daughter actually didn't want to visit the physician, but the mother made her come. which means that she's very reluctant and not so willing during the consultation. And that's very difficult for the student, who by now has had lots of communication skills training and practice. And one of the things one of the goals, the learning objective here, is negotiating and being able to deal with a patient and a third party, in this case, a mother. So these are already some more advanced students at the end of the fourth, beginning of fifth year, where they practice this kind of consultations. We use real 13-year-old pupils from a school, a local secondary school, where they have a drama class, and we train these girls to work together with a simulated mother. It's not their real mother, but it's one of our advanced simulated patient mothers. They're trained to give feedback. The girls are allowed to give feedback from their own perspective, but they're a little bit trained to not do it too roughly to students who are quite nervous when they have to deal with this kind of problem. And the mother is the one supervising during the session, who is very well trained to give really effective feedback and make sure the student really learns from it. And there is also feedback from either a pediatrician, a general practitioner, and a psychologist, but all in a rotating manner. So in every session there is somebody present, but they rotate. And in this film you will see there is a psychologist. She only comes into, you can only see her very briefly, but it's mainly the child, the girl, and her mother you will see. So if you could help me with the next film. Yeah, okay. I'm sorry you can't hear, because even in just hearing you would hear that the mother goes on and on and on, and the daughter is just sitting there, not being able to say anything, but also not wanting to say anything. So here's the story about the headaches. And it's a little difficult to see. The student is really facing the mother, not looking very much at the daughter, listening to her story. And at one point she will try to make contact with the girl. Okay, now she addresses the girl. She just says, well, I sometimes have a headache. And then the mother again comes in, wanting to correct what the daughter says. And what happens now is that they talk together, the mother and the doctor is at the other side of the desk, left out of the conversation. She tries to re-establish contact, and this happens a few times. And I think without the sound, it's probably not that clear for you. So is it a little bit clear about what happens here? Or should I stop it, or should I move on? No, two questions at the same time. Should I stop it? Okay. Again, the mother coming in. They quarrel about she stays at home. She's trying to motivate the students more for this consultation. Well, that's clear now. And of course, her mother is worried about school as well, as mothers usually are. But the girl denies because it's more difficult at school and she's still doing quite well. I think this demonstrates it enough. I think we can stop here. It goes on for a few more minutes, and the student actually will ask some more questions about the headache to make sure she can say something about if it's a migraine or not. So then after that there is feedback. The daughter gives her very natural feedback, and the students like that very much. The mother gives feedback, and the psychologist who is present also gives feedback, involving all the 3 students that are present in this case. And the other 2 students will have a practice round with another simulated patient and another case after this session. We have another surgery. I told you we had 2 surgeries that were specifically meant for students to in this program to practice integrating skills. And this one is the very final communication skills training, where the students have another surgery with 6 simulated patients on a variety of subjects, and they have to go through this session unprepared. And they have to integrate everything: basic communication skills, making contact, empathy, etc., with all the medical knowledge. We make them use guidelines which have been introduced earlier on in the program. They have to prescribe, for instance, really prescribe using the tools they have learned for that. And they have to also implement or use their technical skills, for instance, physical examination. And they have to do this in the context of general practice, so short consultations, we've just introduced this, using information materials. We used to use books, but now they are allowed to use iPads, because most students are better in looking up information on digital things like iPads than in books. But they also have to do that without losing contact with the patient, so that's a very good practice as well. And they also have to handle a mixture of types of consultations and patients and skills. And these are the consultations, and again, don't worry about looking at this in too much detail, but they're history taking, as well as explaining, as well as dealing with non-compliance, doing physical examinations in between, sometimes a full consultation, management, difficult ones as well. For instance, the last one is a consultation about a patient who has symptoms of a sexually transmittable disease, a topic they will see in general practice, and really, really very helpful for them to practice this with a simulated patient. I didn't put any evaluation marks in this presentation, because that would give too much detail. But again, there is some work that's going to be published shortly, and you look it up. The students value this kind of training very, very much. They like making mistakes when it doesn't really matter yet, even though they're a little bit nervous when they work with simulated patients. They know they are not real patients, and it doesn't really matter, because this is meant for learning, and they're allowed to make mistakes, and that will help them do better next time. So I'm going back to the principles of the curriculum design for those of you who are thinking about implementing more communication skills in their curriculum, and to take into account the things that we know about what really works. So who are the learners and what do they need? We already knew that our learners would be medical students. So what we did was an evaluation of the current communication skills trainer among students and teachers and educationalists, looking at strengths and weaknesses. And we, of course, looked at our blueprint in detail, making sure that when we developed a curriculum, the students would meet those criteria at the end. After having done that, we formulated broad goals around those criteria, but we also made sure that for everything we wanted to teach them, the what, that we had specific measurable objectives. We did that for the variety of skills and the types of consultations with the different patient groups and about the different contexts. So every session has very specific measurable objectives as well. And these are checked every time, every month, in fact, by a committee who is looking at these evaluations. Then the strategies, how will we teach them? Sometimes the lectures, but usually the lectures are interactive then. We ask lots of questions in between, show things, ask questions. So not very much just lectures. Lots of self-study assignments pointing to relevant literature, which we do check because there's always some questions when they start the experiential learning in role play or in the skills training with the simulated patients. And then there are video consultations, sometimes of real patients, sometimes with simulated patients, which are always reviewed, and there's always feedback when they've done that. And then very important, what resources do you need if you want to make this work? And for us, that was a very thorough discussion with staff about involving clinical staff as well as psychologists in this program. Every episode has a coordinator. That's, for instance, a surgeon or a pediatrician or a general practitioner or a neurologist, internist. All these specialists are involved in the program, and they have to be, because otherwise you can never motivate enough staff to really be involved in this program and to be trained in giving effective feedback, not just on the medical content, because that's what happens very easily, but also on the communication skills. And if a specialist, a medical specialist, for instance, a surgeon, tells a student that that will work or that will not work in the clinical context of surgery, the message for students is very much stronger when the message just comes from psychologists, because then the student will show a trick when the psychologist is present, and they will forget it when they're doing the real medical stuff. So that is why we think, and there is literature, that it's more effective if you do it this way, and we tried to do this throughout the program. It requires a lot of time, and that's too why you need these clinicians on board, because otherwise you will never get enough time to be able to make a longitudinal program throughout your clinical curriculum. And time always means money, but it's a lot more than that. It's also about the time you need that costs the money more than the money itself. But you do need money. You also need money, for instance, to pay your simulated patients, because you cannot do that on a voluntary basis if you really want to use them in a longitudinal program. So all these things and many more, lots of time for negotiation was needed to do this, and still is needed, because you have to keep up the quality of your program. And of course you have to evaluate if this really works. Are your learners learning? So we have monthly evaluations. We sometimes have extra evaluations. And a few years back, we have really started doing some educational research as well. And the first publications are coming through at this moment. This is the last slide about, the last one has some references on it, but this is the last one about what we are doing now, because you're never done when you've developed a program like this. Again, we are facing a revision of the curriculum. There's a new curriculum reform to come where we will mainly start with revising the bachelor, but that gives us the opportunity to look at the preparation for the clinical curriculum, and we haven't done that really in so much depth as we have done the clinical curriculum, so that's a very good opportunity that we can do it now. But other things that keep constant attention, that need constant attention, are our quality assurance program. And that counts for the facilitators, for the clinicians, the psychologists, the specialists who are involved in these practice sessions. They all follow a course, a local course at the moment, and we're starting to develop a new course that works on the principles of that existing course, as well as of the courses, the TEACH courses. I don't know if you are aware of that organization. It's the teaching a branch of the European Association of Communication in Healthcare that has a number of European courses, all meant for communication skills teaching, but different parts of that. And you can find it, when you look up each on the website, you will find these courses as well. So we're developing new ones ourselves for our specific context. We are very much, we're taking a lot of time looking at the quality assurance of our simulated patients, because they are key in our experiential learning, and good feedback is very essential. One experience of a student with a simulated patient who gives very negative feedback can be very disastrous for a long time for a student, so we put a lot of effort in feedback training for simulated patient, and we have just developed an instrument that we can use for simulated patient portfolios. We validated this instrument, and that is also a publication that is already online but will appear in paper quite soon in academic medicine. And it's an instrument that we hope can be used internationally as well, because it's also available in English. We're always modernizing according to the needs of our patients, so of our society. So, for instance, we are just at this moment writing up or changing cases a little bit to speak a little bit with students and make them practice with patients about the benefits and risks, for instance, of the modern media. A lot of patients look in Google when they have symptoms, and they come to the doctor prepared, knowing what they have, and sometimes it's true and sometimes it's not. But it's very important that as a doctor you know how to deal with patients who come in with their own diagnosis in a way that doesn't influence the consultation in a negative way. And that too is something that you really have to take into account when you teach communication skills. And as I told you, the introduction of iPads and computers in the consultation room, because that's a reality too. Many doctors have their files on a computer, and that's a different way of dealing and taking a history of a patient than when you had that paper file, although that too was important to make students aware that you cannot sit writing all the time. But the computer screen is something different, and not looking up things. You have to learn how to do that and make sure you don't lose contact with the patient as well. We're doing educational research, as I said, and one of the other important things is that we have to tune in, align our undergraduate training with the postgraduate training, so with the training program for general practice and for medical specialists, to make sure what is dealt with and to what level in the undergraduate training and in the postgraduate training. And that too is constant negotiations and quite a difficult task. And I know from colleagues all over Europe that that's not just a problem in our country, that counts for everywhere. So that is about our curriculum, and I expect there will be some questions. I've put on the slides, which, as I said, we can send you, a few of our most recent publications, or publications that are already being processed at the moment and will come out quite soon in February 2013. That might be helpful if you are thinking of developing a curriculum, but you really have to make sure to develop it to your needs, to adapt it to your needs. And you never can copy a program like ours. You really have to adapt it to your own situation. So that's the last I would like to say. Thank you very much for your attention.
Ja, herzlichen Dank für diesen spannenden Vortrag. Es zeigt nochmal, wie aufwendig das ist, ein Kommunikationstraining durchzuführen für eine Gruppe an auch, was hattest du gesagt, 360 Studenten?
Ja.
Müssen
jedes Jahr.
Jedes Jahr.
Jedes Jahr dann.
Das heißt also, dass eine so große Zahl intensiv in Kommunikation ausgebildet wird. Aber man kann andererseits nur sagen, es ist das entscheidende, wichtigste Handwerkszeug. Und von daher, denke ich, lohnt sich die Mühe. Und wir in Hannover haben bisher Anfänge in dieser Richtung, lediglich nur Anfänge. Und die Notwendigkeit besteht, denke ich, für jede medizinische Hochschule, für jede Einrichtung, die Studenten ausbildet, auch ein solches Kommunikationstraining aufzubauen. Und das erfordert natürlich beträchtlichen Engagement und Einsatz und ja auch von deiner Seite, das sind ja mehr als 25 Jahre, die das Projekt läuft. Ne?
Thank you very much. I appreciate the way you are linking communication skills training and medical skills training. And you said that for medical skills training you give immediate feedback. And my question is there a reason for not giving immediate feedback in communication skills? You know, to give it afterwards. We do it the same, but as a psychologist, I prefer giving immediate feedback also for communication skills in form of content.
Yeah, well, that is a choice we made because we like our students to practice a full consultation, and sometimes if you give feedback too early, they cannot correct themselves. So sometimes they can correct themselves in the communication throughout the consultation, and if you would give feedback on the technical bit and on communication skills at the same time, they would probably not get very far. So we do give immediate feedback after the consultation, which is after 10 minutes, 15 minutes. They then get the immediate feedback. But we do not stop. In this kind of practice, we do not stop every time they make a mistake. We have sessions where we do that. I told you the stop-start method. Then we stop and say, well, there's enough to give feedback on. Let's give immediate feedback here. But in these sessions, we want them to practice a full consultation and be able to correct themselves, reflect on themselves, and give feedback on a lot of aspects. The other thing we discovered, if we give immediate feedback, they never get feedback on the second half of the consultation because time is up. So we said, we'll do it this way. And then we have some sessions where we use the stop-start method and we can do it. So that it's a choice. I think both methods are good, and certainly if you mix them. And that's why we like the variety of methods, because each student goes through that whole longitudinal program and has an opportunity to practice many, many times. So probably will get feedback on a lot of aspects as well. Also, one of the other things I would like to say is because we do this, our simulated patients and the student observers too, student observers write, and our simulated patients are very good at remembering exactly what went wrong or where they didn't feel heard or where they wanted more explanation or things like that. So even though we don't give the feedback, stop the consultation at that moment and give the feedback, usually that point is dealt with immediately after, so only 5 or 10 minutes later. But it's also because these simulated patients are trained very well, they're accustomed to this way of working, and some of the simulated patients have worked since 1987. They started as simulated mother and now they're simulated grandmothers or elderly. So that really happens in our program. Is that enough answer to your question? Yes.
Yes, my name is Thomas van Lengerke. I'm involved here in the curriculum here at Hannover. And thanks a lot for your very interesting talk. I have two questions. One, how strict would you be regarding when to start with skills trainings? You said, I think you start in the third year in the clinical curriculum. We start with our communication skills training, well, in the second year, even in the first year a little bit. And we have quite encouraging experiences. I agree with your point that the medical content should be clear, but wouldn't you think that early experiences are quite also interesting and instructive for the students? And the second one is, do you know of any endeavors to evaluate our curriculums, their effects on the praxis of the physicians in the field after they have studied? I mean, is this all worthwhile when you look at the praxis?
Yeah. Well, two very good questions, of course, and there's no just one answer to any of them. First, maybe the second question, because that's very important. Does it really matter how you train the students? What has the best effect on their performance later on? It's very difficult. There are a few studies available. There was one comparing the curriculum in Maastricht to the one in Leiden, so from my country. Leiden didn't have very much and started much later. Maastricht started very early and had a lot, although they stopped quite early. They stopped nearly at the beginning of the clinical years. In the first year, I think the Maastricht students of clinical work did much better, but in the end, after a few years, it was all the same. So I hope that whatever method there is, students will learn from it. That refers back to your first question where you said, shouldn't you start a little earlier? Aren't early experiences good for students as well? Yes, I think they're very good. It's not that we don't do anything about communication, but the emphasis on the real systematic skills training, where every student has these practice rounds and receives personal feedback, the emphasis starts quite late. And they do a lot in the preparation before, small bits, small things about communication skills as well, because I do think it's important. What we wanted to do, it was also trying to bridge that gap between practice and real, between training, classroom training, and real clinical practice. And there's something called just-in-time learning. And we tried in this way to do something about just-in-time learning. And it seems to work very well. What we want to do, and that was on my last slide, and that's very, very difficult, is to evaluate, to really study the effects of the communication skills training. But there are so many confounders, it's very, very difficult to study. We're working on it. If I found an answer, I'll let you know, but I haven't found it yet, and I don't know, because we looked at the literature, I don't know of any study that has really managed to study the link between a program and the effects in clinical practice. So that answers your questions?
Okay. The last question then.
And we can always answer questions in the interval if they want. They can come to me.
Dankeschön. Ich bin Ilse Marie Horst. Ich habe als Ärztin gearbeitet und war dann lange Berufsschullehrerin. Und durch diese Berufsschultätigkeit ist mir aufgefallen, dass Sie sprechen ja auch immer von Klassen, Entschuldigung, dass ich auf Deutsch spreche, dass schon die Organisation des Studiums ein Grund für gute Kommunikation sein kann. Ich meine, dass Gruppen gebildet werden. In der DDR wurde mir berichtet, dass zu Beginn des Studiums 20 Studentinnen und Studenten zusammengefasst worden sind und die das ganze Studium zusammengeblieben sind. Hier in der MAH habe ich das so gekannt, dass man zu 500 in einen Hörsaal kam und dann alphabetisch in die Anatomie kam und irgendwie anders in die Physiologie. Wie machen Sie das in den Niederlanden? Jetzt muss ich aufhören, lange Frage, Dankeschön.
I can't say about the Netherlands because we have 8 medical schools and they all do it a little bit differently. But I think most of them, and certainly we in Nijmegen, do it in exactly the same way. So we have groups in the bachelor years, so in the 3 first year, there are groups of 12 students. They have a mentor that is longitudinal as well for the whole bachelor. And in the master, new groups are formed, but they stay together if possible, and if students don't get pregnant or ill or leave, etc. They stay together for the second 3 years, and those groups are usually 15 students, and 2 groups of 15 students every month. So we have cycles of monthly rotations and things like that. But that's very important too, that you have a safe learning environment with people you know who you learn from and who not, but you can also help others learn. I think that's very important as well. We couldn't tell everything in the presentation, but you're certainly right. That's very important. That too helps, because these sessions are very safe, because the students already know each other, and when they're with 3, they know if I give you good feedback, I'll get good feedback. If I'll give you nasty feedback and negative feedback, I'll get negative feedback too. They know each other, so that's very important. Thank you for the question.
Ja, nochmal ganz herzlichen Dank.